So guys, today's class, like I promised, is going to focus about the complications of multi-fetal gestation. If you've seen my previous class, with my previous lecture, if you were there, then you would know that there are complications which are there in multi-fetal gestation, which include fetal growth restriction, a discordance in growth, complication of preterm delivery, prematurity, intrafetal death, and so on and so forth. But there are certain complications which are specific to monochorionicity, usually in dichorionic placenta or multi-fetal gestation with a dichorionicity. You do have the complications I just enlisted, which were there covered in my previous class. But if you're talking about specifically monochorionicity and its complications, today's class is dedicated to one of them, which is called Tdts, that is twin transfusion syndrome. I'm going to talk about what exactly it is, how do you diagnose it, and what is the management. And this will sum up as a 5 marks short note question. And of course, anything less than that, you can easily write down what I'm going to discuss in today's class and its complications. So let's talk about monochorionicity's complications, which will be the first one of which is twin transfusion syndrome. And now, what exactly happens in monochorionicity? There is one placenta which gets shared between the two fetuses, as a result of which you have a discordant transfer of elements between the two fetuses. Somehow down the lane, one fetus becomes the donor and one becomes the recipient in a way. Okay, in a very rough way. Actually speaking, the donor and recipient we'll be talking about later when we talk about the trap sequence. But right now, in a relative way, one becomes the donor and one becomes the recipient. And what are we talking about? Where exactly are these anastomoses? So let me just tell you that the anastomosis is two kinds. One is, let's talk about what Tdts is. So in Tdts, there are two kinds of anastomosis: superficial and deep. Amongst them, you have arterial anastomosis. The flow in arteries is much more than the flow in veins. So usually when I'm talking about arterial anastomosis, they usually confine to 75% of the anastomosis in the placentae. Then comes the arteriovenous and then veno-venous anastomosis. And because it is somehow speculated that there is an uneven distribution of the nutrients, the flow, and everything inside, which leads to one twin getting smaller by the day and the other one getting bigger by the day. But that does not mean that one is at a loss and the other one is at a gain. Actually, both are compromised. How? I'll just tell you. And mind you, this thing you have to tabulate. Alright, so just pay attention and you will be sorted with this entire Tdts. If you see my lecture, you will be able to write down a 5 marks answer easily, even without referring the book. So just listen up. The complications in donor twin, the complications in the recipient twin. Automatically, the donor twin, you will have oligo. Here, you will have poly. I'm talking about oligohydramnios, polyhydramnios, the first sign. Automatically over here, the bladder will be absent. Okay, I'm not mentioning anything about the bladder over here. Automatically, this will be a fetal growth restricted baby. And in over here, there'll be hydrops developing with time. Not just that, because of extra volume that it's getting, it'll have congestive cardiac failure. Heart failure because of excessive volume overload. Since it's giving, it will have anemia, and since it's receiving, it's going to have polycythemia. And with polycythemia, remember always when I'm talking about polycythemia in whichever context, wherever, polycythemia, that means increased viscosity of blood. Increased viscosity per se is responsible for many complications, amongst which thrombosis happens to be one. So these are, if you tabulate them in the form that I'm now, remember one thing, that I'm in between giving you tips and tricks to write down your questions. In fact, the way I write it down on the board, that also gives you a rough idea as to how you would like to put it on the paper, so that it's easy for the examiner to understand that this girl knows this answer. All right, so make it easy for the examiner. So use more of tabulations, more of flowcharts, use lots of diagrams, practice them at home, keep scribbling your diagrams when you're even at work. Just keep things absolutely discreet in front of the examiner, so they know that the essay form mein likhe you are not trying to beat about the bush. You know it. All right. So anyways, these were the complications. Now, how will you diagnose that this particular pregnancy is going towards Tdts? Then comes the management, isn't it? So let's talk about how do you first diagnose, and if there are any criteria for diagnosing. See, a very rough criteria, I'm not going to write it down. A rough criteria in diagnosing Tdts. First of all, it's an ultrasound, which helps you to diagnose. And one of the criteria of ultrasound is one vertical pocket more than 8 centimeters and the other one less than 2 centimeters. That will be a rough way of telling that this is going towards, or it has got established Tdts. But that does not help much. Why? Because when do you intervene? How do you intervene? Do you wait for one of them to become more than 8 centimeters and the other one to become less than 2 centimeters? Or you intervene it before that? And even if you do intervene, what is the mode of intervention? How do you go about it? So there comes a very important staging. Remember, when I'm talking about Tdts, this is a thing which comes in the package. If you don't know this, everybody presumes you don't know about Tdts. That is Quintero et al. Staging. All right? I'll make it very easy for you. You'll remember it as I write down. All right. Let's talk about Quintero staging. Quintero staging for, remember, Tdts stages. All right. So stage 1, 2, 3, 4, and 5. First thing that comes into being is poly and oligo sequence, which is there in stage, right from stage 1. Do you take an action on that? Do you not take an action on that? But you should be skeptical that this thing is going in that direction. All right. So poly-oligo sequence. Then comes bladder gets, the donor twin bladder gets out of the field. You're not able to see the donor twin bladder. That is not there in stage 1, but it comes in stage 2. Then comes deranged Doppler flow. All right. So it is not there in stage 1. It's not there in stage 2, but right from stage 3 it comes over. A derangement in Doppler flow of both the twins. All right. How and when, that we're going to discuss later. But derangement in Doppler flow. The other stage is hydrop starts setting in. Not in 1, not in 2, not in 3, but in 4, yes. And finally, the last stage of all, death of one of the twins. That's stage 5. If you remember this chart, if you just remember these things, in the order I've written down, in the sequence I've written down, obviously first to come is a poly-oligo sequence. Then suddenly the bladder of the donor twin cannot be visualized. Then comes deranged Doppler flows. The next stage is hydrops and the next stage is death. When do you intervene? How do you intervene? This was not just the staging, but also the diagnosis of Tdts, when to intervene and how to intervene. There are also a set of guidelines, green top guidelines on monochorionic pregnancy and its management, and I'll be posting it in the group of those people who have subscribed to my channel, my classes, the paid group. And there are also one more guidelines which I've shared with the rest of the group. You can study from there as well. But yes, to be very sure that there are 2 guidelines. One is specific for monochorionic pregnancy, and in them a little more discussion has been done on Tdts. And now comes the management of Tdts. If it's stage 1, let me tell you, usually 70 to 75% cases, that's what 3/4 of these pregnancies, they usually have a benign course and they are not hazardous. Problem starts with stage 3. That means this setting up of deranged Doppler flow. The perinatal loss without intervention in stage 3 is from 70 to 100%. Maybe of one of the twin. So how do you intervene? Now, I'll just name the modalities. You are not expected to write down a thesis on those modalities. You should just know. But one of the modalities I've spoken in detail about in one of my classes, that is on fetal therapy. With the people who are interested in knowing a little more about it, you can just go through my class. It's a very simple 8 or 10 minutes class, like all my rest of the classes. In between work also, you can watch my video and you will know what I'm talking about. You'll have a little more matter to write about. The management of Tdts, there are 4 modalities. All right. One of them is amnioreduction. Okay, amnioreduction. You just go through ultrasound guidance. You put in the needle, the spinal needle, and you keep drawing the liquor out of the recipient twin, you know, to make it a little easy for the recipient twin. But then again, the pathology remains over there, so there is a huge chance of recurrence. That's not very popular therapy. The second thing is septostomy. You make a small hole in the dividing membrane between two. I'm talking about monochorionic diamniotic pregnancy over here, obviously, and you make a small hole. So there is equivalence, you know, the distribution of the amniotic fluid is equal. Then again, it's not very popular. The third one is a selective termination of one of the twin. Would you like that kind of a management? If I even speak about it, it doesn't look very convincing at all. Obviously, it will not look very convincing to the parents. It's probably one of the last resorts. And then comes photocoagulation of the anastomosis, which I'm sure we are able to achieve only the superficial of them, is an invasive procedure. And if you want to know more, you can refer to my class on fetal therapy. You'll be able to get more highlights of this particular procedure. But yes, photocoagulation through ND-YAG laser of the anastomotic channels between the placenta, because of which there is this discordance of amniotic fluid and the corresponding corroborative complications. That will be another modality to save the fetus from going and proceeding into TTTS. The recurrence is still seen, the complications are still there, but yes, that's the management. And with this, I finished my complication of TTTS. And the next class, I'm going to take up more complications which are specific to monochorionic pregnancy. Watch out for my video. That will be the third part of multi-fetal gestation. And hopefully, we are able to wind up for that and finish off with the multi-fetal gestation in the third class.